Okay, I think we can begin. Again, thank you guys all for joining us. I'm Alex Quickly from Shield, Illinois. Our monthly webinar, semi-monthly, is back, and we're talking about endemicity. What the heck does that word even mean? And the Omicron variant, two very important topics in the COVID universe right now. We're joined by Dr. Christopher Brooke and Dr. Rebecca Smith. After their presentations, we will allow for some time for questions and answers. So please look for the Q&A button on your interface here in Zoom, and we will get to those after the presentation is done. I believe we will start with Dr. Brooke. Please take it away, Chris.
Sure. Yeah. Thanks for having us here today. So I'm going to give kind of a quick rundown on sort of in general what we know about the Omicron variant, and then happy to take questions a little later. I first want to just start by kind of going over some basic background on what is a variant and where they come from. And so I apologize if this is you guys have heard this a million times. But basically these variants that we keep dealing with are just descendants of SARS-CoV-2 that have picked up a small number of natural changes in their genome sequence. This is a very common thing that all viruses do. One of the hallmarks of virus biology, and one of the things that makes them really interesting, is that they make tons of random mistakes when they're copying themselves. And these are just, we call these mutations. And most of these sort of random mutations are bad for the virus, like the vast majority of them. But every now and then the virus hits upon a random mutation or a combination of these mutations that turns out to be beneficial. And so the analogy that I like to use is like a slot machine. So you can think about the virus basically just posted up at a slot machine, pulling the lever over and over and over again. Most of the time, and every pull of the lever is like infection of a new host. So the vast majority of the times, these aren't really going to result in a jackpot. You're going to get just random mutations that aren't particularly beneficial to the virus. But every now and then, the virus hits the jackpot and it picks up a mutation or a cluster of mutations that actually make the virus better at doing what it does, which is replicate and spread between hosts. Okay, so this is a natural process of virus biology. And so it's become a problem for us because we get these variants of concerns, which are variants that have picked up the ability to outcompete the previously circulating SARS-CoV-2 types because they have become more contagious. They picked up mutations or groups of mutations that make them better able to transmit between us, that make them more contagious. So can I get the next slide, please? So we've been dealing with these variants for a while now. You're all probably tired of hearing new Greek alphabet letters. This is a plot on the bottom of the slide kind of showing the prevalence of different variants since the emergence of the virus into the United States. So these numbers are from the US. And you can see, starting back in 2000, we had the emergence of sort of the first variant of concern, Alpha, which sort of took over. You can see it in red there, and it outcompeted a lot of the viruses, the SARS-CoV-2s that were circulating before that. Then earlier last year, we had this Delta wave. So the Delta variant emerged, replaced Alpha because it was more transmissible than Alpha. And then, of course, the reason I'm here today, around Thanksgiving of last year, scientists in South Africa reported that they had found a new variant circulating there that was eventually called Omicron, that had a very concerning set of mutations. As we've all seen, that virus very rapidly spread around the world, and you can see it's just sort of incredible takeover of the SARS population in the United States, going from basically undetectable around Thanksgiving to almost all almost all viruses circulating in the United States right now. Okay. So I'm going to talk a little bit about what makes Omicron different from other variants that have circulated previously. Oh, can you go back? One wasn't quite done. Yeah. But the key message here is that the reason this virus has taken over is because it's more transmissible than prior variants. And part of this is most likely because it is much better able to replicate and transmit in people that have prior immunity against the virus. So those of us who've been vaccinated and or who've been previously infected with the virus. So that's one of the things that makes this Omicron variant so contagious and has allowed it to so rapidly outcompete the prior variants like Delta. Okay, now I'm ready for the next slide. Okay, so Omicron is really caught the virology community off guard because it really is kind of very different from the other variants we've seen. So if you look on this graph on the right, this is kind of a busy graph. Really what it just shows is the number of mutations in the spike protein, which is this protein on the outside of the virus particle that is what our immune system sees and tries to target to protect us. And so the number of mutations that different SARS-CoV-2 viruses have in that spike protein is shown kind of more mutations higher up on this chart. And so basically all the variants we've seen to date, alpha, beta, gamma, all of the viruses we've seen are down here, and they have in the neighborhood between 5, 10, maybe up to 15 mutations in spike. And then you have this clear outlier group up here, which is Omicron, totally different, very different from the rest of the viruses that we've seen. It has over 30 mutations in the spike protein. So this really surprisingly high number of mutations. And most of these mutations are concentrated in regions that are preferentially targeted by our immune system. So if you look in the lower left here, this is the structure of that spike protein that sits on the outside of the virus particle and that the virus uses to bind to and get into our cells. And the mutations are shown in different colors. And so the upper left, this is the kind of original gray SARS-CoV-2 that first started spreading around the world. And then you can see the different variants that have come out afterwards. And you can see alpha, beta, gamma, et cetera. They all have, quite a few mutations here, but nothing like Omicron. You see just tons of these purple mutations. Okay, so this virus is highly divergent from what we'd seen before. We still don't totally know where it came from. There are a couple main hypotheses. The most likely place where Omicron emerged from is from someone who was immune compromised and had a long-term persistent infection with the virus. We've seen a few examples of this now where people who are immune compromised, where their immune system is not able to effectively control the virus, and the virus hangs out in these individuals for weeks to months. They have a persistent infection. And that's kind of a unique setup and opportunity for the virus because it gives that virus a chance to try out different mutations. And it really serves as sort of, it gives the virus an opportunity to sort of do this trial and error and just pull that slot machine over and over and over again. And so we suspect that it was within an immune compromised patient that Omicron was given the chance to pick up all of these mutations and eventually arrive at a set of mutations that made it so transmissible such that it could then sort of take over. Okay, can I get the next slide, please? Okay, so this is the big question that obviously is kind of front and center for most people, which is how well do vaccines work against the Omicron variant? We were lucky at the beginning of last year that we began to roll this vaccine out. I think a lot of us were looking forward to, once everyone was, or the majority of people were fully vaccinated, that we would really kind of get a handle on the virus. And so having a variant like Omicron emerge is a little bit, of a letdown. And so the large number of spike protein mutations present in Omicron was one of the first things that got people concerned, because a lot of these mutations are in regions of the spike protein that we know the immune system binds to. And so just looking at the genome sequence, there was reason to speculate that this virus might be a lot better able at escaping either vaccine or infection-mediated immunity than any of the previous variants that we've seen. And so a lot of scientists around the world have been working like around the clock on this since this virus was first reported out at Thanksgiving. And now we have a pretty clear idea of what makes Omicron different. And what I'm showing on the bottom are plots that's using an approach called antigenic cartography. And basically what this method does is it measures how similar different viruses look to your immune system. So two viruses that are really close to each other on one of these antigenic cartographs are seen as very similar by your immune system. So if you're immune against one, you're probably going to be immune against the other. Whereas the more distant they are, the more distantly related they appear to your immune system, and the less protected you might be against one if you have immunity against the other, if that makes sense. Okay, and what you can see from these two plots is that Omicron is separating out in its own little group away from all the previous variants that we've seen. And this is because, in fact, this virus, all these mutations really are affecting how your immune system sees it. And we've now shown very clearly that immunity raised either by vaccination and or by prior infection do not protect as well against Omicron because it does look so different to your immune system. And this is really what we think has driven its extremely rapid spread, across the country and other countries. Basically the fact that Omicron is much better able than Delta or previous variants to replicate and transmit between people who have been vaccinated or previously infected is really a huge factor driving its emergence. Okay, can I get the next slide, please? Okay, so that's the bad news, that that Omicron is just much better able at replicating and spreading in people who have immune protection against the virus. The good news is that the ability of prior immunity to protect us from severe disease or hospitalization or death is still retained. Okay, so while vaccination is not going to prevent you from getting infected with Omicron and potentially transmitting to others, it still is dramatically lowering the chances that you're going to get severely ill from an Omicron infection. It also does decrease the odds that you're going to get infected in the first place. And if you do get infected, it does decrease the odds that you're going to transmit to other people, but it doesn't prevent that. Okay. But these data are from a recent paper that came out and that's really trying to quantify how frequent people are either getting infected or being hospitalized as a function of their vaccination status. And you can see on the left, this is looking at just case numbers. So, reported test positive cases. You can see this arrow indicates when Omicron first became prevalent in the United States. And you can see across all groups, vaccinated, unvaccinated, and boosted, that you're seeing spikes in case numbers. Okay. This is just a function of the fact that vaccination is not sufficient to completely protect you from getting infected with Omicron. It lessens the chances that you'll get infected, but not all the way to zero. And so, we're seeing increased breakthrough infections now that Omicron is prevalent. But the key thing is here on the right-hand side, this is age-adjusted numbers of hospitalizations per 100,000 people. You can see this throughout since vaccination and then boosters became available, there's this huge difference in risk of hospitalization between unvaccinated and vaccinated people. That was true before Omicron. But now, even as Omicron has taken over and you're seeing way more breakthrough infections of vaccinated people, that the numbers of vaccinated people, and particularly people who are vaccinated and boosted, are staying low, whereas they're just skyrocketing and the unvaccinated population. So yes, Omicron has diminished to an extent the ability of vaccination to protect against infection and transmission. It is still conveying, luckily, substantial protection against severe illness and death, which is great news. Okay, can I get the next slide, please? And finally, I don't want to take up too much time here, but I want to address this other question that I get a lot, which is, whether there will be more variants or not. And the one, from the very beginning, this virus has been, it's been difficult to predict what's going to happen, and a lot of predictions get, turn out not to be correct. but this is one prediction that I think I'm 100% safe in making, is that there will absolutely be new variants. We will continue, after Omicron. We're already seeing sort of different versions of Omicron begin to compete with each other, and some sort of subgroups of Omicron turning out to be more transmissible than others. And I guarantee you, we are going to see new variants after this, either descended from Omicron or descended from Delta, or potentially descended from an earlier variant, which was kind of what happened with Omicron in the first place. But anyway, wherever it comes from, we will see new variants, and this is going to happen for years to come. Okay, so on the one hand, that's kind of a bummer. But the thing to keep in mind is that as more people layer on more immune protection through vaccination, as well as through infection, overall, you're going to see the disease burden associated with SARS-CoV-2 infections continue to decrease. So even as new variants emerge and we continue to get waves in cases, what I think we're going to see is that the spikes in hospitalizations or severe infections or deaths are going to be much lower with each of those subsequent waves of infection, because we're going to be more protected based on our immune system. Okay, so as the population as a whole gains more protection through vaccination, preferably, and also through infection, this virus will eventually become more like the other respiratory viruses that we already live with, like influenza virus, like the other coronaviruses that cause the common cold. And what I'm showing down here in the bottom is not coronavirus. This is another antigenic map, similar to what I showed for the coronaviruses, but for the H3N2 subtype of influenza virus, which emerged into the human population in a pandemic in 1968 and has continued circulating to this day. So the vast majority of flu cases that occurred over this winter have been H3N2 viruses that are direct descendants of the pandemic virus from 1968. And what you can see here is that since 1968 on the left, as you move towards modern day, so 2009 is on the right, you can see this virus is shifting in antigenic space. Okay, so each one of these dots is a new variant. You can think of as a new variant. And you're seeing, and you see this process where over time, the virus keeps changing how it is seen by your immune system in order to allow it to keep replicating and spreading between people who have prior immunity. Okay, and this is exactly what seems to be happening with SARS-CoV-2. You can kind of think of that first cluster of dark grayish blue dots under the HK68 is the first group of variants we've seen over the first couple of years of this pandemic. And Omicron is the first variant that kind of shifts over into that second cluster over EN72. So we think that we're starting to see a process play out with SARS-CoV-2 that's very similar to what we've seen in the past with influenza virus. So that's all I really wanted to talk about today. I'm happy to answer any questions or any follow-ups that come in the Q&A, but for now, I will turn it over to Becky. Thank you.
Thank you, Chris, and thank you for the really good lead into what I'm going to be talking about. I've actually talked about influenza as kind of an idea of where we're going with SARS-CoV-2, and I think that will play into a lot of what I'm going to talk about next, which is what is endemicity? And the word endemic has been thrown out a lot lately, and we've been debating among the epidemiologist community of why it is that the word endemic is being used so much and seems to be being misused so much. And one of the reasons could be that many people don't know what endemic means because it doesn't have a really clear definition yet. One thing you need to understand is that epidemiology is a fairly new field. We've got a long history, but as a really professional field, it's a fairly new field. So a lot of our definitions are still solidifying. Next slide, please. So when I say there's a lot of interest, this is a Google search. The red line indicates searches for epidemic, and the blue line is searches for endemic. And you can see that we've just had this huge spike in interest in the term endemic. What does endemic mean? Are we endemic? Where are we? So I'm going to try to walk you through what endemic means, and are we there yet, and what we can expect with it. Next slide. So in the process, I'm going to quote many friends, colleagues, people I respect from their Twitter. Know that I don't go to Twitter for sources of information all the time, but I found that some very trusted people share a lot of useful information. So these are some of the people I trust. And a lot of us have found that the interest in endemicity may be based on this misunderstanding. And first, endemic does not mean good. We don't want endemic disease. Endemic is not good. It means here, forever, for long term. And also, endemic is not end. The word end is not actually part of endemic. Endemic means among the people. So endemic means it's here, it's among us. We're not getting rid of it. So understand that endemic does not mean the end of COVID-19. Endemic does not mean a good thing. Endemic is a different thing altogether. Next slide, please. So there are two definitions of endemic, and that's part of what the confusion is. Actually, there are more definitions. The original definition of endemic is something that exists in a particular place. So malaria would be endemic to a swampy region. From a technical perspective, as an epidemiologist, what I teach in my graduate class is that endemic means steady state or predictable. So the graph on the right there shows 3 different examples of endemic disease. There is this kind of steady state, a little bit of noise, but it's kind of just there all the time at a low level. There's this seasonal disease where you see a spike at some point in the year and then it goes away again. Or there's the waves of cases where it's a regular wave, we kind of know what it is. So steady state doesn't mean the same all the time. It just means it's kind of a predictable, that on average over the year, we see about the same amount year to year or time period to time period. And we contrast that with epidemic being more cases than expected. So the definition of an epidemic is that it's more than endemic. Endemic is what we expect. Epidemic is more than we expect. Right now, what we're experiencing is a pandemic, which means it's epidemic everywhere. Pandemic and endemic are not different terms. They're just different concepts. So the idea of pandemic is that we have spread going on everywhere all the time. Endemic means that we have something that's predictable, that we know what it is, and usually endemic is different in different areas, and we'll have endemic diseases in some areas that don't exist in others. We'll have different levels of endemic diseases in other areas, but it's not something that we look at globally. This is an endemic disease. That's not something we talk about. Next slide, please. Okay, so that's the scientific definition. Go ahead to the next slide. The practical definition is, this is the amount of infection we're willing to live with, or the number of infections that we can expect based on what we're willing to do to fight it. The cynical way of putting it is, this is the amount of death that we will live with without making major changes to our lifestyle. So if you can click again, this is politics. This is not science, this is politics. This is how much death and illness are we willing to accept before we say, you know, we should do something about it. And this is a different definition altogether. We learned last year with influenza that we can eliminate childhood deaths from influenza by shutting down all schools and having kids wear masks everywhere. Politically, they're not willing to live with that. They're willing to say, you know, we have to have schools open, and we're willing to accept that that means that during influenza season, there will be pediatric deaths. We never talk about this decision, but this is a political decision that is made, that we understand that a certain amount of disease will happen with these diseases that we live with. And we're willing to accept that because the alternative is something that we just can't politically manage. That's very different from a good thing. So you see, when I say endemic does not mean good, it means we are making a political decision to accept a certain level of disease and death, and before we make a change. Now, endemic and epidemic are not actually opposites, but when I say before we make a change, when we get to an epidemic point, so say influenza again as an example, there's a certain amount of influenza that we expect and kind of accept, but we will see these epidemic strains of influenza coming out where it's a really bad flu year. And sometimes we make choices. So when the last influenza pandemic came out, in areas where there were an outbreak, they would shut down schools. Normally, we won't shut down schools for influenza, but in a bad year, we will. So that's endemic versus epidemic. Again, it's what we're willing to live with before we make other changes. Okay, next slide. So some examples of endemic disease, and these are endemic diseases, some here in the US, some in other parts of the world. West Nile virus, those of you in Chicago, hopefully you're familiar with West Nile virus. If you're not, West Nile virus is endemic in Chicago. In Illinois, we get about 60 neurologic cases, that's severe neurologic symptoms, and about 1 to 20 deaths per year. We spend a lot of time and effort. My lab spends a lot of time and effort trying to predict where those cases will be and trying to prevent them, tracking the mosquitoes, looking at where the virus is showing up. We spend a lot of time and effort trying to predict the 60 neurologic cases and the 1 to 20 deaths per year. 1 in 4 COVID-19 survivors, one estimate says, has long-term neurologic impacts. So you can imagine if we were going to say we're going to accept the amount of spread we have right now, and 1 in 4 of those will have long-term neurologic impacts. This is much different from West Nile virus. And we don't just accept West Nile virus, we have a lot in place to fight it. Tuberculosis, 1/3 of sub-Saharan Africa is thought to be infected with tuberculosis. We spend an enormous amount of time and energy and money fighting tuberculosis in sub-Saharan Africa. Right now, 1/5 of the US has been infected with COVID-19. So we don't want to get to the point of where we're like tuberculosis. And to be honest, most of those tuberculosis cases are what we call latent, which means people don't even know they're infected, like COVID-19, and they don't need any treatment. But if they get HIV, if they get cancer, any other thing that affects their immune system, they're suddenly vulnerable to long-term impacts. So tuberculosis, again, not a good thing, but it is an endemic disease in sub-Saharan Africa. Influenza, it's an endemic disease, but also an epidemic disease. We have epidemics sometimes. It causes 12,000 to 16,000 deaths per year in the US. The COVID-19 mortality rate is 4 times higher. So I would argue that we don't want the amount of COVID-19 circulation that we see with influenza. But those are all examples of endemic disease. So you need to see what I'm saying, that endemic is not good. Endemic is a technical or political definition of something that we're at this point, and this is what we can do to keep it at this point. We're not willing to do more. Next slide. So remember, endemic does not mean harmless. People will get sick with endemic disease. People will get sick. Next. Endemic does not mean mild. People will still die. Nobody would call tuberculosis mild. Nobody would call neurologic West Nile virus mild. People still get sick, people still die. And endemic does not mean ignorable. It means some of us are going to be working long-term to control it. It means that the government will spend a lot of your tax money controlling it. So endemic means that it's going to be here long-term and we're going to have to work at it long-term. Next slide. So is COVID-19 endemic now? Hopefully you already know the answer to this. It's no. COVID-19 is not endemic now. And Bill Hanaj has had the best way of putting it. COVID-19 is not endemic right now in the same way that the moon is not a hamster right now. It's just, endemic is not even in the realm of possibility right now. We have uncontrolled global spread. That is not endemic. That is still a pandemic. Okay, next. When will COVID-19 be endemic? Usually people who understand that it's not yet ask me, when is it going to be endemic? And Angela Rasmussen is fabulous. And she has pointed out that people have made predictions about the end of the pandemic over and over and over. So many people have wrongly predicted that the pandemic is going to end. It will end. But it doesn't mean that the virus is going away. It's just so we're not going to have endemic spread on multiple continents. You can click again. So the questions we have to ask when we think about when will it be endemic? Will the immunity that we've gained during the Omicron surge last? Probably not. There's already indications that the next variant, which has been identified as potentially being of concern, BA.2, may cause reinfections of people who have already had Omicron. The biggest question is, how long will our immunity last? Right now, we're seeing reinfections happening as early as 60 days, and with a new variant, even sooner potentially. Next. Will a new variant appear? As you heard Chris say, yeah, probably. We will probably see new variants. We will probably continue to see new variants for the rest of all of our lives. The question is, will the new variants evade the immunity we've gained? And hopefully you've learned from Chris a little bit about that. The other question that we have is, will the new variants be milder? So a lot of people have made the point that, oh, Omicron is mild, right? Well, it's milder, which means that if you get infected, the probability that you'll end up in the hospital is lower, but the probability that you'll get infected is higher, and they kind of balance each other out so that we have more people in the hospital now with Omicron than we did in previous waves, simply because more people are infected. And so with the new variant, if it's milder, that might not be a good thing if it's even more infectious. And the other thing we have to ask is, will people continue to lighten mitigations too early? And unfortunately, I have to say the answer is probably. We are already hearing from people, you may have heard the urgency of normal. People saying, okay, kids need to be able to take their masks off in school. We need to lift mask mandates. We need to lighten up on testing. We don't need to do all of this. It's too early. You have to understand that as we see the numbers going down, that doesn't mean the infections are going away. It means that the rate of infection is slowing down. Lots of people are still getting infected. If we lighten mitigations now because we're on a downslope, it just makes it more likely that we'll get the next variant faster and more people will get infected and we'll have more hospitalizations and more deaths. We have to maintain mitigations if we want to get to endemic sooner. Next slide. So how do we get to endemic? Remember that endemic is not a great thing, but it's better than where we are now. So to get to endemic, we need to bring cases under control first. So we need to test and mask and improve ventilation. Those are the best ways that we can bring cases under control. And then we need to increase immunity, which is vaccination. Part of that is to improve access. We have great vaccination rates in certain communities. In other communities, vaccination rates are not as good, not necessarily because of opposition to the vaccine, but because access is difficult, because of schedules, because of language barriers. We also need to improve global distribution. The more spread that we have in other places, the more chances the virus has to pull that slot machine lever and get a variant that will help it spread further. So more cases under control, more immunity. Next slide. And what will living with this mean? And Newsweek last week or 2 weeks ago had a great article about the forever virus and what the future of COVID-19 is. And one quote that I really like from there is that we need to come up with a long-term plan. So can you click? So first, we're going to need regular boosters. So just think like your annual flu shot. And I know Moderna at least is working on a flu COVID dual shot, which would be great. We're going to need to think about mask wearing long term, especially during seasonal surges or during local surges. And I know people have politicized masks in this country, but masks are not a horrible thing. My kids forget to take them off when they come in the house. And if they keep cases down, great. I will say that having small kids, I have had fewer colds, even with them back in school and daycare, because they're wearing masks all the time. So I'm all for masks. Also, they keep your nose warm in the winter. We will need better ventilation. So cholera used to be epidemic and pandemic and even endemic in certain places. And how did we get rid of cholera, say in the city of London, which is the source of the beginning of epidemiology? We changed the way we handled sanitation. So how do we get rid of respiratory diseases? How do we control them better? We need better ventilation. And I know this is not an individual choice you can make, but we need to advocate for improving ventilation systems. Next, we need better public health infrastructure. Our public health infrastructure was hurting prior to the pandemic. It had been sorely underfunded for years, for decades, and the pandemic has not helped. So we need to improve funding for public health. We need to improve training, and we need to build up that public health infrastructure so that it's there to help us fight all of these diseases. Next, we need better surveillance. So we need systems of surveillance so that we can test when we need to test, that we can build up our testing capacity for COVID-19, for SARS-CoV-2, and for other viruses as we need it. So we need that testing capability in place. Next. And so I'm sorry that that's not a really happy topic that I was covering, but endemic is not a solid term, and I think that's helped it to be misused. And I'm hoping that that will help you understand a little bit better what epidemiologists think about when they think about endemic, and what we can do then to make sure that we get there and that we get to an endemic that's a little bit better than where we are now. And I think Chris and I can both take questions now.
Thank you both, Dr. Brooke and Dr. Smith. If you are here still watching, there's the Q&A section on your menu. Feel free to type any questions you have in there. We'll get to as many as we can here, provided we get these in before 5 o'clock. Our first question, hi, thank you both for presenting. It was fascinating. Due to the nature of SARS and influenza having higher rates of mutations, can any country achieve herd immunity, or will it have to be a global effort?
So one requirement for herd immunity is that we have long-lasting immunity. And unfortunately with SARS-CoV-2, we have not seen long-lasting immunity after infection. So that's going to make it difficult. And the vaccines have been good at preventing disease, but not as good at preventing infection, which I think is going to make it highly difficult to have what we would call herd immunity.
Yeah, to second Becky's point, I think it's actually, I don't know that it's possible to get herd immunity against a respiratory pathogen just due to kind of the quirks of how the immune system works in the respiratory tract. We could be in a situation where we're so well protected against this virus that none of us, I mean, this would be like, this isn't realistic, but just in a magical situation where we were all so well protected that we never got sick, we would still probably be spreading the virus because it can replicate a little bit up in our nose and spread it onto someone else. So I don't think herd immunity is you're ever going to see it for a respiratory pathogen.
Next question. How much would a variant of this virus have to change for it to be considered a whole new virus?
It wouldn't. I mean, we would be tracking that. We would see that process play out, that evolutionary process, and it would be clear that it was a descendant of SARS-CoV-2. So there's no situation in which it would evolve into something that we no longer called SARS-CoV-2.
Next question. At what point after how many variants do we have SARS-CoV-2 vaccines that change every year, like flu vaccines?
That's a great question, and we don't really know yet. I think the Omicron, as I was kind of hinting at, we all suspected that you would see the emergence of a new variant that was different enough, what we call antigenically distinct enough that our immune system sees it differently. I don't think that most people, myself included, thought that we would see it this quickly. It's an open question. Are we going to see new antigenically distinct viruses every year, or is it going to be more like flu where it's every few years, or something else? We don't know yet, I think, but we have the technology to, I think, adapt our booster. I would hope that we don't need to get a coronavirus booster every single year like we do for flu, but that might, maybe that is where we end up. I don't think we know yet.
Next question. How does the availability of treatments impact the definition of endemicity?
So the availability of treatments doesn't impact the technical definition of endemicity, but it impacts the political definition of endemicity, because what we're willing to live with, if we have effective treatments, we're willing to live with a lot more spread and a lot more infection if we feel that most can be treated very easily. So politically, it's a lot easier to allow more spread if you know that people can be treated. So it changes not necessarily the definition of endemic, but the level of endemic that would be allowed by the public health decision makers.
Next question. With such a global shortage of vaccines, how will vaccination ever be able to reach underdeveloped countries? And then what happens with the pandemic there?
Yeah, that's a great question. It really depends upon the decision making of the countries where the companies that make different vaccines are based. It's going to take both. It's going to take people understanding that they can't just treat this as an opportunity to make money. And so making sure that the deals are in place such that the intellectual property needed to make effective vaccines is distributed to other countries, so that other countries outside of the United States, for instance, can manufacture mRNA vaccines. It's also going to take the support of wealthy nations to help build the manufacturing infrastructure in other countries to help make that happen.
Yeah, it is good news that fairly recently a patent-free vaccine came on the market and is now being produced in multiple places, and the technology to produce it is being shared. It's not an mRNA vaccine, but it is at least a patent-free vaccine that will really help things a lot.
Next question, sort of a jump off on that. Where are we with the development and approval for a vaccine for young children?
As both of us have children under 5, so we understand the interest in this. Pfizer submitted data to the FDA this week to request an EUA for the first 2 shots of their mRNA series for young children. Understanding that those will be the first 2 shots of a 3-shot series. It's a very interesting procedure. Not sure how that will go with the FDA, but the hope is that if the FDA approves that it will be approved within this month, and hopefully we will see shots going out at the end of the month. Moderna is planning to submit in March. So we're still on the waiting period. Pfizer is taking a different approach than we've ever seen. So that should be interesting.
And just anyone who's on the fence about these things, I have one 6-year-old who's fully vaccinated, and I have a almost 3-year-old who we will get vaccinated as soon as it's available.
And ditto that for me with an 8-year-old and a 4-year-old, that the 8-year-old is fully vaccinated, 4-year-old will get the shot as soon as it's available.
Excellent. Can you talk about additional variants of interest or concern that are currently active around the world? What do you think is coming next?
Yeah, so there's a few kind of, so when we say Omicron, like all of the Omicron viruses are not absolutely identical. And there are now kind of 3 different sort of subgroups of Omicron that are out there. None of them are really of great concern at this point. It looks like there are a couple that may be a little more transmissible than the sort of first Omicron that took over, but there's nothing to suspect that immunity against the first Omicron is not going to also be highly protective against these sort of related Omicrons that are circulating. In terms of where the next variant comes from, that's really hard to say. I think during the Delta wave, everyone thought that we would see variants evolve as descendants of Delta. Then instead, we get out of nowhere this Omicron variant, which is a descendant of a much, much older SARS-CoV-2 lineage that replaced Delta. And so we don't know if it's going to be the continued evolution of predominant variants like Omicron or Delta, or if you have little pockets of the virus in places that we're not really surveilling, where it's continuing to evolve in ways that we're not tracking. One of the things that's really concerning is the large number of animal species that this virus has moved into, from white-tailed deer to different cat species. So there's lots of those represent new places where the virus can evolve in different ways and then potentially jump back into people. So I think it would be foolish of me to say, yes, the next variant is going to be this. It might be, but it might not be.
Starting to run out of time here. We have time maybe for 2 or 3 more questions. Another variant related question. What would you say the likelihood is of a variant evolving that causes more severe disease than previous variants?
I think pretty unlikely. So the thing about disease severity that I think gets lost in a lot of discussion is that it's driven by 2 different things. Okay, there's the inherent virulence of the virus, like how sick the virus would make you if you had no immune protection whatsoever. And then there's how much immune protection we have. Okay, so there's no reason to suspect, so the virus itself becoming more or less virulent, that may or may not happen. There's a lot of talk about the virus evolving to be less virulent. That's all BS. It could go either way. It could not change much at all. But the much more dramatic factor that's governing overall disease severity in the population is how much immune protection there is. So even if if a new variant is a little more virulent, a little less virulent, if you have immune protection but through vaccination or prior infection, you're going to be much less likely to get severely ill with that virus. So I think that the benefits of immune protection that we're gaining through more vaccination, more infection, are going to drastically outweigh any fluctuations in virulence inherent to new variants.
Maybe 2 more. To an admitted non-expert as myself, does the kind of work being done on pan-coronavirus vaccines represent as large as a quantum leap as it seems? Or is this just another garden variety tool in the toolkit to building individual and community immunity?
No, I'm glad someone asked that question. I think it's super promising. And I think that that is the key to potentially a future where we don't need a booster shot against coronavirus every year. That we could actually engineer a vaccine that protects against all the different ways, all the different variants that might emerge. And even better, one that protects us against all of the thousands of other coronaviruses that are circulating in animals right now that we have to worry about jumping into people to make SARS-CoV-3 and SARS-CoV-4. So I am super optimistic about pan-coronavirus vaccines. I think we know how to do this. The early results are really promising, and I'm really hopeful that gets us in a situation where maybe we get a new coronavirus vaccine every 10 years. Or less even.
And one final question. Great job breaking down such complex topics. I guess it's a compliment first, then the question. Can you please explain or break down the science behind the new CDC guidelines of 5-day quarantine?
Becky, do you want to do this, or?
I can explain a little, although I will say I am not a fan of those guidelines. The thought is that most people, by the time they get their infection diagnosed, that they're only going to be infectious for 4 to 5 days. And so that the rest of that isolation period would be unnecessary, because as long as they're recovering from symptoms, most people at that point are no longer infectious. It's based on the assumption that it probably takes you a couple of days to actually get your test and get your test result and start isolation, which varies from place to place. It's also based on a lot of assumptions that I don't think are rooted strongly in science. We have never seen the data that the CDC used to make that decision. That said, I would be behind that idea of lifting isolation after 5 days with a negative antigen test. Because our own data from research that Chris and I did found that people who are still infectious at 5 days are highly unlikely to be positive on an antigen test. And people who are not infectious are less likely to be. So I do support that with a negative antigen test, but without it, I'm just a little bit cautious, and I just don't like it.
Yeah, I think that there were practical concerns that went into that in addition to the science. I think that they were concerned about the healthcare system collapsing because so many people were infected and quarantining or isolating, that they needed to be able to pull staff out of isolation sooner so that they could keep hospitals going. And I think the absence of a negative test result was driven by the lack of availability of antigen tests. So I think that if those concerns hadn't existed, you would not have seen that new result, that change. You would have seen something more like what Becky described, where either we would have stayed at 10 days isolation, or it would be 5 days with a negative antigen test result.
That's excellent info, excellent insight from both of you. Thank you again, Dr. Brooke and Dr. Smith, for your time and your effort into these presentations and helping to educate the public. For those of you who joined late, or maybe want to share this with a loved one or a friend, maybe helps them learn something about what's going on with endemicity. I had it right before. It's a hard word. Or the Omicron variant. Remember, this will be up on our YouTube channel by tomorrow mid-morning, and we'll push it out on Shield Illinois' social media channels as well.